and welcome to day one of the Nurse and Allied Health Network sessions. My name is Janelle Reichhuber, and I'm a nurse at the University of Kansas Health System, and one of the co-chairs of the Nurse and Allied Health Network.
Hello, my name is Jamie Lederer, and I am the nurse practitioner at the University of Pennsylvania with the Interstitial Lung Disease Program, and I'm the other co-chair of the Nurse and Allied Health Network. We are really excited to have this special session for all the nurses and allied health members who play such a vital role in the care of patients with interstitial lung disease. This is the second summit at which we've had our own session dedicated to the nurses and allied health providers. We continue to look forward to the ways that the Nurse and Allied Health Network will grow and participate within the Pulmonary Fibrosis Foundation. We will hear tomorrow, during part 2, an update on all the great work and various projects the working groups within the Nurse and Allied Health Network have been working on. But in the meantime, we would love for those of you who are not already involved to please jump in and join us. Please feel free to reach out to us throughout the remainder of the conference or even after the conference, and we'll get you plugged in. You can reach out to Janelle or myself via the chat or the message section in the conference platform, or you can send either of us an email. Thank you to the Pulmonary Fibrosis Foundation for providing this time for us to learn and network as a group. A really special thank you to Erin Mahoney, our Nurse and Allied Health Network Summit Chair, for all the hard work you put into organizing these sessions. And a special shout out to Jessica Shore for all your help as well.
So as Jamie said, we have a great session planned for you all today. We're going to start off by hearing from Lori Flint and myself talking about the role development of the ILD coordinator. Jamie will then present on understanding the diagnostic pathway in ILD, and then Lanier will discuss integrating palliative care into clinical practice. We will then have about a short 10-minute break and come back to close out our session with Jennifer and Carolyn presenting on addressing the challenges of care in ILD. Susan will then talk about what patients wish they would have known at the time of diagnosis and partnering with families and caregivers with support resources. While we won't have a live Q&A session, please feel free to reach out to any of our speakers, Jamie or myself, with any questions. You can always post them to the Mobilize platform too, and we can start some great discussions. We look forward to hearing your questions and your feedback. So with that, let's get
Welcome to Role Development of the ILD Coordinator. I'm Lori Flint with the University of Michigan.
And I'm Janelle Reichhuber with the University of Kansas. Here is our objectives for this presentation: identifying and understanding your role, learning your role, advancing your role, and balancing your many roles.
In order to identify and understand your role, you need to know your definitions, and a big one is ILD. So what is ILD? ILD, or interstitial lung disease, is an umbrella term used for a large group of diseases that cause scarring or fibrosis of the lungs. The scarring causes stiffness in the lungs, which makes it difficult to breathe and get oxygen to the bloodstream. Lung damage from ILDs is often irreversible and gets worse over time. You may be thinking to yourself, well, I know what that means, but can you explain that to your patients so they can understand it? You will have a deeper dive into learning about this disease and its processes in later sessions. But right now we want to focus on our role and what that means. So the next definition we want to talk about is care coordination.
What does it mean to coordinate care? According to the World Health Organization, care coordination is a proactive approach to bringing together care professionals and providers to meet the needs of service users to ensure that they receive integrated, person-focused care across various settings. The term care coordination is a relatively newer term and has had many different interpretations, but note what it does not include. It does not give a title, degree, or position of who the professional or providers are. So who is doing the coordination, or who can be a care coordinator?
We all can. Nurses, social workers, research coordinators, medical assistants, physician assistants, pharmacists, pharmacy technicians, respiratory therapists, and anyone else who we may have missed. Yes, we all come from different backgrounds, We all carry different titles or positions, and our institution and roles are more than likely different. However, we all are coordinating the ILD patient's care. Janelle and I have been doing this for a few years and are going to speak about our roles as ILD specialty nurse coordinators at academic centers. But our care coordinating and what we do at our own centers is still different. And part of this reason is because of the teams we have in place. So think about who is a part of your team's, part of your center's team. And if you need a visual, here's a look at who could possibly be a part of your team.
Now we know this is not a comprehensive list and not all centers have these potential players, but take a moment to see if there is someone on here that maybe you can add to your team or see who can help you in your role or that you can delegate things to so you have more time with the most important member of the team, the patient. For example, at the University of Kansas and University of Michigan, we have met with our pharmacy teams and they have provided us with dedicated pharmacy technicians that do our prior authorizations, assist with appeals, and help with obtaining medication assistance or free drug for our patients. KU's pharmacy has 340B status and other accreditations that allow them to be a specialty pharmacy, meaning they can ship our specialty medicines and our pharmacists can assist with medication education and monitoring. The pharmacy team will do check-ins with the patient and let us know how they are doing with the new med starts and if there are any issues. The best part of this is that it is all documented within the patient's medical record. We have also recently been provided with a dedicated pharmacist who is now embedded into our clinic and is working on developing her role. Another amazing team member we have at KU is our film library. We have an electronic system in which we can request outside images to be clouded to KU, and then we request our film library to let us know when it has arrived. This has greatly helped reduce the amount of phone calls and delays in imaging requests.
Also at the University of Michigan, due to patient safety concerns, our IT department helped us integrate our lab monitoring program into our Epic system. Prior to this, we had two separate systems that did not talk. So the only way to tell if labs were being done is if you had access to the program. Now everyone can see if a patient is on a lab draw protocol, and if so, which specialty and what medication, what drug is being monitored. It shows how frequently the labs are being done and what and when labs are needed. Learning a new system came with growing pains and also brought to light the amount of time we were spending on trying to keep up with patient lab compliance and requesting results back to our center. We addressed this with our nurse manager and she worked to hire a separate medical assistant that is solely responsible for our lab monitoring system. Nurses still review results and based on protocols we have in place, hold or make changes as needed. But this change has made it so we can now focus on other nursing tasks, such as coordinating patient care and addressing patient and caregiver concerns and questions. These team players were added because of a question and or need, and because we sought out to others to help us. If you do not ask, you will not know if there are other team members that can help be added for you, your team, and your patients. But how did we get to that point to seek out help, voice our concern or our need for change? We started first by learning our role.
Now you may think you already know your role, but a wise person once told me to keep myself as an active learner. And I think that is really good advice and is applicable to our next topic, learning your role. So how did you learn or are currently learning about ILD? I did not have a formal orientation to outpatient medicine, let alone to ILD. But when I started, my providers wanted me to sit with them during the patient clinic visits. It was a lot to take in, and I had to go home and look up several terms. But that time and experience was very impactful for me in learning about these diseases. Hearing the repetitiveness about the disease process, the medications, the findings on the CTs, and seeing the actual patient that I would later be talking to not only helped me to learn about ILD, but also helped me to be able to reiterate what the provider had told the patient. This is important because more than likely after a new patient visit or any patient visit, that patient and their family are probably very overwhelmed and are going to go home, process everything, maybe do some internet searching, and you will get a phone call to rediscuss what the plan was and what was all said. And let me tell you, the first time I had to return a patient phone call or assess a patient over the phone, I was terrified. I didn't want to say the wrong thing, and I was worried I would miss something because I couldn't see them. And as a nurse, your visual assessment skills are everything. I remember literally putting my hand over the phone and saying, "They said they have a cough. What do I do?" Luckily, I had an amazing mentor who showed me the hold button and walked me through it. We now have training headsets at our center, which allow new hires to be able to listen while the person who knows what to say can talk. So these things are some things to think about. What does your center offer to new ILD coordinators, and how can you help to train and prepare them?
I have also learned a lot in our MDD or multidisciplinary discussion. Now, granted, the first time I participated in this, I was pretty overwhelmed. But again, the repetitiveness of hearing our radiology and pathology team members interpret the cases helped broaden my understanding of these diseases and made me learn even more new terminology like mosaic attenuation and fibroblastic foci. Definitely terms I did not learn in nursing school. It has been very interesting to hear different cases presented, hear the different thought processes explained, and to see firsthand the collaboration that goes into diagnosing the patient. Let me put it this way. Going to MDD is like staying at the Holiday Inn. You definitely walk out thinking, I've got this. Now, if reading and watching videos is how you'd like to learn, another great resource to mention is the PFF website. It contains webinars and the ILD Nurse and Allied Health Network Handbook, which is a very good overview of all things related to ILD and caring for ILD patients' needs. You can request copies to be mailed to you, which we have done to provide our new fellows, nurses, medical assistants, and anyone else on our team who wants to learn more about ILD. You can just print it off the website as well.
If collaborating and peer discussion is how you like to learn, the Nursing and Allied Health Network uses Mobilize to ask questions and learn from each other. The Journal Club meets monthly to discuss new research articles, which then prompts discussions into how we can integrate the study's outcomes for evidence-based practices within our clinics, or even how to publish one yourself. A shout out here to Catherine Fenwick, a new publisher that shared her article during one of the Journal Club meetings. And finally, an amazing but sometimes a little overwhelming, especially if you are newer to ILD, is the PFF Summit. Not only can you network and learn, but you get CEUs too. Hopefully, you'll log out of these conferences and feel inspired, refreshed, and more knowledgeable on everything ILD, which makes it a great time to go out and start sharing this information with the patients and caregivers.
The information that we are going to share with the patient depends upon their diagnosis and plan. We typically get this from the MDD. There may have already been discussions at the office visit about what the suspected diagnosis and plan would be, but once it is confirmed at MDD, how does that information get back to the patient? Does the patient get a phone call from the provider or from you? Is there a note that is placed in the chart about discussion and plan that the patient can reference back to and that can be shared with other team members within your center? Who else needs to be notified of the plan? Does the referring provider or the primary care get a letter or a phone call? Is it discussed or decided upon that the referring doctor sending the patient will continue to manage care, or are you going to share the patient? Or has the patient decided to have their primary ILD team be you? And then who is placing the orders and following up with them for the patient? These are all important questions that need to be discussed and decided to help ensure everyone is on the same page, not only for the patient to know whom to call, but also for continuity of care and safety. The ILD care coordinator can help facilitate these conversations and help close that communication loop, all while making sure the patient understands the plan, because the most important person you will share knowledge with is the patient. And how do you do that?
We do it through effective communication. Some things to think about when you are talking with a patient. Have you asked them what mode of communication they prefer? A phone call or a MyChart portal message, or maybe even a letter? I know messaging may seem easier and faster, but sometimes that phone call can tell you a lot more. You can hear conversational dyspnea on the phone. You can't hear that in a portal message. The other potential problem with messaging is, although it may say they are active, they may not have read a single message you have sent. So be sure to look back at the last few messages and see if they've been read. Also, have you educated the patient on when to send a portal message versus calling? And if they are to call, do they have the correct number? Remember to try to use easy to understand terms. So when you are talking or sending a portal message, try not to use abbreviations. And if you do, explain it or type it out, and then put the abbreviation in parentheses. This will help the patient start to correlate the medical language and associated abbreviations. We know everyone learns differently. So have you asked your patient how they learn best, or if they have any barriers to learning? Are they visual or verbal learners? Also, before you provide that education, maybe ask if they want to get a pencil and paper to write things down, or see if they want their caregiver or loved one to listen in and be present with them. Have empathy. Remember, when talking with the patient at this time or during the course of their care, they may have seen multiple providers, had several tests, sometimes duplicated, all while anxiously awaiting the results of these and an explanation for their symptoms. They may have seen results pop up in their portal before hearing from a provider and are scared or confused of what they mean. Remember, these patients have a lung disease and they may have trouble breathing while talking. So just because a patient pauses for a second, they may not be done talking. They may be trying to catch their breath. Try to have resources ready to provide to them and ask if they would like for you to mail them or provide them with the PFF website address. We know that knowledge is power, and the education we provide to these patients and caregivers help them to make the best decisions for themselves. So how do we educate the patient?
We know there's a lot of education that needs to be done, and usually the first topic that is discussed is medications. The PFF has medication resource sheets for both antifibrotic and some immunosuppressant medications. They come in Spanish and English and are easy to print and hand to the patient to go over. Having the written literature about medications ready to give to the patient, as well as links and websites to share, not only saves time, but ensures your patient has the correct information. And don't forget, you can utilize your external team members too. Some drug manufacturers provide nurse educators who are specialized in these medications and diseases and can also be a resource for you and your patient. They can call, provide education and follow-up, as they are there to help the patient be successful on their medication. And those that I have been in contact with have provided me feedback regarding any issues or concerns. In other words, they can be an extra set of eyes and ears for the patient. A difficult and constantly evolving point of education is patient symptom management. Symptoms such as cough and breathlessness will vary based on each patient, as well as the degree of fibrosis. As you evaluate and educate and assess your patient through their care, make sure they know what to look for, when to communicate with you, and any ways or tools we have to help their symptoms. It will be important for the patient to have this information to help support their self-care management.
Another important topic that needs to be addressed is pulmonary rehab, which is something you can make sure is offered to your patient. Although this treatment may initially be overlooked due to testing and medication initiation, it is often the most important part of an ILD patient's journey. Here they can gain tools for self-care, meet others with similar diagnoses, and have medical staff evaluate them twice weekly, which could potentially prevent a hospitalization. Finding a location that was close and convenient for the patient was a challenge before COVID, but now we have had several centers close and reduce their numbers to accommodate for social distancing. And although that has created additional challenges, it has also opened up other opportunities. Some centers have created their own online pulmonary rehab resources, and the PFF has developed a pulmonary rehab toolkit. These opportunities, although not the same as being in person, have helped those that are immunocompromised and that are waiting to get into a center up and moving in the interim. Support groups. We know that patients learn differently, and I think we need to be aware that the kind of support a person needs may vary as well. It is important to make sure the patient and caregivers are aware of this option so they can decide what is best for them. Although the patient may not be ready to go or be involved initially, their caregiver might, or vice versa. Either way, make sure you have shared your resources regarding the local and online support groups. And if you are unsure of what your area has to offer, both the local and telephone support groups can be found on the PFF website. There are also various social media support sites and groups as well. It is crucial to make sure the patient and the caregiver realize they are not alone in this journey. and that there are others who understand what they are going through, as this can make a difference in how they can live with and manage their disease. We know the education you will provide will change as the patient disease progresses, which leads up to other important topics of education for the patient. And although these topics will be covered in more detail in upcoming sessions, we want to touch base on a few of them.
Oxygen. The path for oxygen is one of the hardest and I think the most frustrating that we can encounter in this role. Between DMEs, insurance companies, and equipment issues, it was already challenging, and then the newly added issues associated with the COVID pandemic that include the lack of oxygen tanks and supplies, makes this system more difficult not only for the ILD coordinator, but for the patient who is trying to adjust to this new change. When I think back to the beginning of my ILD coordinating role, I was not aware of all that was involved with oxygen, especially the different oxygen devices, insurance requirements. The PFF did not have their oxygen resources yet, unfortunately. I ended up working to try to figure it out on my own, talking with DMEs and trying to understand all the insurance nuances. The more I learned, the more I felt I was able to help patients through this process. I do remember, though, during a support group meeting with oxygen as a topic, a patient's wife, who was a retired nursing professor, say right to me, "You did not provide us with enough information so we could make a good decision with my husband's oxygen." That statement has forever remained with me, as I felt I had let them down. I then ended up working with her and my support group members to write information they wanted to have shared about oxygen and the oxygen process that could then be given to patients newly being started on oxygen. We were able to get this statement approved for a SMART phrase or a DOT phrase to share with all patients starting oxygen. I now not only spend a little extra time with patients that are starting oxygen, but provide them with the SMART phrase info as well as the PFF oxygen resources. Lung transplantation. This will be a question that is asked often by patients. They will want to know if the time comes, could they have a lung transplant? You should be aware of your center's basic evaluation and listing criteria, like age and BMI. And if you don't have a transplant center, what centers can you refer your patients to? If you do not know this answer, it's important to find it so you can share that with the patients. And even if you do have a transplant program, it's still good to know what other centers are near you, as your patients may want a second opinion, and it's important to help them get that assistance if asked. Palliative care. Talk about this early and often, not only with the patient, but with your team members, so they are aware of the importance of having palliative care services for your patients. Palliative care can help with symptom management, be that extra set of eyes on the patient, and assist with end-of-life care planning. KU recently added a palliative care team into their pulmonary clinic, and as one would expect, it has been a blessing for the staff and patients there to have palliative care services evaluate, assist with the care of the patients. Clinical trials. Make sure you are aware of any clinical trials in your center. Regardless if you have research at your center or not, you need to know where to find the current research associated with pulmonary fibrosis to assist with patients as questions are asked. Here are some important sites for you, as well as to share with your patients who may be looking for or are interested in clinical trials. The PFF has their pipeline, and then clinicaltrials.gov.
So we just covered a lot of information about the education that is needed for these complex patients. Are you feeling a little overwhelmed? Now put yourself in the patient or caregiver's shoes. Some things we can do to help ease the information overload is to create a center-specific Ild Guidebook or folder for the patient and caregiver. It can include the Pulmonary Fibrosis Information Guide that is provided from the PFF, the PFF website address, the local support groups information, local pulmonary rehab contacts, and your contact name and number for follow-up. Try to make these accessible so even if you are unable to be in clinic, your providers or other support staff can easily give them to the patient and caregiver. Now, we realize some in this group may already fall into the expert level. However, you are never on cruise control within this role. There are so many opportunities to advance and build, not only for you, but for your patients and for those that help to monitor and coordinate their care. You can do this by expanding your communication with others. Think about the communication with your patient and ways to improve this at your centers. Lori discussed DOT phrases or SMART phrases. These can help save time and also provide clear and consistent messages to the patient. You can provide in-services to teams in your area to help disseminate new information. This can be done with pulmonary rehab groups, the local support groups, pulmonary function lab technicians, research coordinators, medical assistants, and other nurses. You can reach out to local or rural providers, especially if they have referred patients to you. This helps build partnerships, which not only help with the collaboration of care for those patients, but possibly future patients too. Make sure it is known during these times that you are a resource and they have your contact information for any follow-up. You can become an advocate through the PFF, either nationally or in your state. Also, you can encourage patients to use their voice and get involved with advocating for changes too. You can become a member of an organization like ATS or CHESS. Did you know there are working groups currently trying to change policies for patients through these organizations? I didn't until I started networking here with others.
Journal Club. There has been an increase in research for pulmonary fibrosis. You need to be aware of the journal articles, studies, and data that is out there so you can be informed for you and your patient. You can also be part of a journal club. I, of course, promote the one with the Nurse and Allied Health Network, or even you can do one within your own center or with your own team members. Perhaps have a session talking and presenting after your MDD. I have in the past even started a journal club for the nurses in our medical specialty nursing group. It was a great way to meet up with my nursing colleagues, as well as read and discuss articles from topics across various specialties. The information I have learned from the Nurse and Allied Health Network Journal Club, including the discussions we have had about the articles we are presenting, have been invaluable for me. I feel it is like a support group of sorts. We are learning and talking with others who are going through the same issues or situation, all while discussing the most recent data and evidence. It helps to know we are not alone in the issues, problems, or questions we may have. I always thought it would be great, and one day may happen, that one of our journal club discussions will prompt a research project among us. And if you are thinking, yes, it would be a good learning opportunity to have a journal club after our MDD, we can offer some help. Hot off the press, we have a few journal articles that you can read and share. Of course, besides starting your own journal club, you can let us know if you have an article or working on a research and would like to present at the Nurse and Allied Health Network in the future.
Definition time again. Balance, a condition in which different elements are equal or in correct proportions. We all know it has been a difficult last year and a half between the stress of COVID and changing schedules with both work and home life. Let me just say, it is okay to feel like you do not have balance. Sometimes you may feel like you are rocking everything, and other days you may feel like you aren't winning at all. And that is okay. And for those that feel like they're rocking it all the time, please share with us how you do it. But seriously, remember to pay attention to how you are feeling and how you are doing. Do a self-check-in because you can't pour from an empty cup. So take some time, unplug, get up, move around, don't overextend yourself, figure out what healthy outlets work for you because everyone balances our roles differently. For example, some say, I don't read work emails on the weekends, and others feel less stressed when they do. Just remember, there will always be things in life that you may not be able to change, but you never know until you ask. So if you need help or you feel there is something that can be improved upon, ask. And it may be just the thing that really helps to give you the balance you need.
So bottom line, we want to thank you. Regardless of how you and your center works, the ultimate goal for all of us is to walk alongside the patient in their journey with pulmonary fibrosis, as we know they cannot do it by themselves. So all the education you and your team do and all the resources you gather to provide to the patient is so crucial for their journey, and it doesn't go unrecognized. And I think we can all say this, it isn't a job, it is a passion.
So to wrap this up, we hope you take away some of these key points. If you can sit in with patient visits, do it. You will not only get to meet your patient and their family, but you will learn a lot. Attend your MDD conference. Get involved with the Nursing and Allied Health Network. Attend the summit. Check out the Pulmonary Fibrosis Foundation's website. It has a ton of great resources. And try to take care of yourself. Remember, you cannot pour from an empty cup. Thank you for your time and attention.
Hi, welcome. I'm Jamie Lederer. I'm the nurse practitioner from the University of Pennsylvania's Interstitial Lung Disease Program. I'm here today to talk to you about the diagnostic pathway in interstitial lung disease. We have a brief time together, so it's kind of going to be a crash course, but we'll cover the highlights of what we do when a patient comes into clinic and presents with interstitial lung disease and how we try to reach their diagnosis. So let's get started. Let's start with that I have no disclosures to share with you. And a quick overview, we're going to go over the differentials that we see in interstitial lung disease. We're going to talk about the pertinent things we should focus on when we're taking a history of a patient with interstitial lung disease. We're going to go over some of the imaging findings that we may see when we're looking at CAT scans related to patients with interstitial lung disease. We'll review the exam findings that we may find that might help us decide what's causing this interstitial lung disease. We'll talk about some of the additional testing that we send during this workup, and then we'll review the role of a biopsy or not biopsying a patient. So let's start with what is interstitial lung disease. So interstitial lung disease encompasses over 200 conditions. It's kind of like saying, I have a car, but what kind of car do you have? So when a patient comes to our office and they say, someone told me I have interstitial lung disease, they're often looking for more clarification into what their diagnosis is. But overall, this family of conditions involves inflammation or fibrosis in the interstitium or the wall of the alveolus. This inflammation or scarring causes difficulty in oxygen diffusing from the alveolus into the bloodstream. So you can see pictured here that when the inflammation makes the wall thicker, it's more difficult for oxygen to diffuse across that membrane. It also makes the lungs stiffer. So when we talk about the different differentials that we see in interstitial lung disease, these are the major ones that make up interstitial lung disease. So we're going to see about 20% of them be idiopathic pulmonary fibrosis or IPF. We're going to see about 20% of them be connective tissue disease related interstitial lung diseases. 20% are going to be chronic hypersensitivity pneumonitis, about 20% of sarcoidosis. And then we're going to have other interstitial lung disease or pneumoconiosis or things that are kind of more occupational related. So when a patient comes into clinic and we're going to work them up for interstitial lung disease, I think of it a lot of putting the pieces of a puzzle together. Sometimes we use all the pieces, sometimes we don't use all the pieces. Sometimes they don't fit together so nicely, but we try to put together their history, their exam, their labs, their CAT scan into a nice puzzle to come up with a diagnosis. Sometimes we utilize this piece over here, the biopsy, and sometimes we don't. When we sit down and start talking about what is this interstitial lung disease, the first thing we can do is step back and say, do we know what caused this interstitial lung disease, or do we not know what caused this interstitial lung disease? So when we talk about lung diseases, the etiology is known. We're talking about things that include exposures, such as inorganic exposures, exposures to asbestos, silica, hard metals, coal, dust. We're also talking about organic exposures like birds, hay, mold, mycobacteria. Their lung disease may be related to a medication or a drug that they've taken, such as nitrofurantoin, amiodarone, methotrexate, a chemotherapy they may have received. It may be related to their smoking, and then we're talking about things like DIP, RBILD, LCH. Could be related to a connective tissue disease, such as rheumatoid arthritis, polymyositis, dermatomyositis, scleroderma, or Sjogren's. When we don't know the etiology, we skip over to the other half of this chart when we talk about unknown etiology causes. And so there are rare forms of interstitial lung disease like LAM and vasculitis that would fall under this category. Things like sarcoidosis, it's a granulomatous lung disease that we don't know the cause of. And then we have our idiopathic interstitial pneumonias. The big one being IPF or idiopathic pulmonary fibrosis, and then our non-IPFs, which include our NSIP, COP, LIP, and AIP. So when we want to figure out, do we know what the cause is? The big thing that we can do is talk to a patient about their history. It's really important that we dive in and take a good history for the patient. So things that we want to make sure that we're asking about. Is there any mold damage in your house? Is there any mold damage where you work? Do you have a hot tub with standing water? Do you frequent a sauna? Things like this may push us down the path of thinking this is hypersensitivity pneumonitis. We want to ask about birds. Do they have any pet birds at home? Are they in an area with a lot of birds? Do they have down feather bedding, down feather coats? Again, this may push us in the direction of hypersensitivity pneumonitis. We also want to make sure we ask about medications and radiation. It's really important to ask about kind of current medications and know what your patient's taking, but we also want to know about previous medications because those medications are important as well and may have resulted in some of the lung damage that we're seeing. So you want to go through their list and ask about other things as well. You want to talk about any chemotherapies they've had, any radiation. This may push you into thinking that this lung disease is drug-induced or radiation-induced. I will caution you to say that we do see patients on some medications, and those medications may be a culprit, but that's not actually the cause of their lung disease. This is when the puzzle gets real tricky. We also want to talk about their occupations. And again, it's important to discuss current and prior because their prior occupations may be the one that was causing an issue. I've had many patients, when I ask what they do, they talk about what they're currently doing or what they retired from doing. And it's really important to help them look back as well. You want to ask about hobbies as well, because some patients' hobbies, such as woodworking, may be contributing to their lung disease. You want to talk to them about their smoking. You want to talk about kind of when did you start? When did you stop? How much did you smoke? Are you still smoking? And then it's also really important in today's age to talk about vaping and e-cigarette use. Sometimes that's one that gets missed in our history. Sometimes when we're talking about smoking, we start to think about things like RB-ILD or DIP. Again, smoking does not mean it is these two lung diseases, but it could be. We also want to talk about their family history. Some of these interstitial lung disease are familial. So you want to ask, does anybody else in the family have these lung diseases? Or did anyone else in your family have lung disease? How old were they when it started? Are they still alive? What was the trajectory of their lung disease? And then we want to talk too about symptoms of connective tissue diseases and myositis. So you want to ask them about any skin changes, any joint changes, any muscle weakness, dry eyes, dry mouth, swallowing issues. All of the review of symptoms that is going to lead you to believe that maybe this is connective tissue disease related. After going through their history, you also want to look at their CAT scan. The CAT scan pattern that we see can be quite helpful in deciding what type of interstitial lung disease this is. So you really want to look at a high resolution CT scan. So that's a CT scan that is done without contrast, has thin section images, is done supine and on inspiration. You may find that other images are helpful, like prone imaging or expiratory imaging, but at minimum, you want CAT scan that was done supine and on inspiration. The Pulmonary Fibrosis Foundation has actually put out a beautiful position statement about what constitutes a high resolution CT. So for the sake of time, I won't dive in and read that all to you, but know that it's on the Pulmonary Fibrosis Foundation's website and that you can take a look at that to see if the CAT scans that you're looking at with your patients meet the criteria for a high resolution CAT scan. When we're looking at imaging, one of the first things that we want to talk about is this a UIP pattern or a non-UIP pattern? This is going to help us narrow our differential. So what constitutes a UIP pattern or a non-UIP pattern? Let's talk about it a little. So in 2018, both ATS and Fleischner revised their guidelines as to what constitutes a UIP pattern. So when we're talking about a UIP pattern, if we say this CAT scan meets criteria and is definitely a UIP pattern, we can confidently say if we were going to biopsy this person and take a piece of their lung tissue, on that tissue, 90 to 100% of the time, we would find a histologic pattern of UIP as well. So we don't have to move forward with that biopsy because we're confident that that's what we would find. That's why it's important to be able to figure out if this is a UIP pattern or not. So a UIP pattern, which has been defined by both groups as being subpleural and basal predominant, often heterogeneous, and having honeycombing with or without peripheral traction bronchiectasis or bronchiolectasis. If you don't meet all of that criteria, the CAT scan may fall into what we call a probable UIP pattern. So looking at the two groups, the way they've described a probable UIP pattern is it's still subpleural and basilar predominant, has a reticular pattern with peripheral traction bronchiectasis or bronchiolectasis, and it lacks honeycombing. That's the big thing. Without the honeycombing that we see in that definite UIP column, you cannot say it's UIP. You have to take a step back and say, this is probable UIP. The ATS group says that you may have some mild ground glass opacities on your CAT scan as well, and that you'll still meet criteria for probable UIP. The next group of CAT scans that we look at is our indeterminate column. So these are the CAT scans that we sit in clinic and we look at it and we say, this isn't UIP. This isn't something else, but what is this? It's really, truly indeterminate. So the Fleschner group says this can be variable or diffuse in distribution. ATS still defines it as subpleural and basilar predominant. They both kind of say it has features that don't suggest an etiology. Fleschner says it's inconspicuous features. So, like I said, it's that CAT scan that you look at and you say, what is this? And then our last group of CAT scans that we look at are the CAT scans that we look at and we say, okay, this isn't UIP, but this is features that really look like LAM, or this has features that really look like organizing pneumonia. So when you look at the CAT scan, there's an alternative diagnosis. Those are the 4 ways that we break things down when we're looking at a CAT scan to evaluate for interstitial lung disease. So to take a quick look at some of the components that we just talked about. So honeycombing. Honeycombing are these small cysts, generally on the periphery of the lungs. And these are very common in idiopathic pulmonary fibrosis, although they are not required, and they are also seen in other interstitial lung diseases. You may see traction bronchiectasis, which is this thickening of the airways related to the scarring in the lungs. You may see what we refer to as ground glass opacities. So the picture almost looks hazy. It looks like someone smudged the picture. This could be inflammation. This could be scarring. These are the ground glass opacities that we refer to. And then when we're looking at the distribution on the CAT scan, we're looking, is it peripheral and basilar predominant? So is it around the edges and at the bases? Is that where you find most of the changes? So these are a few of the findings that we find on CAT scan. There are many other CAT scan findings that we could discuss today and things that we could go through. We're gonna skip it now for the sake of time. You'll pick it up in some of the other talks that you hear throughout the summit, and then you'll also be able to dive in a little on your own. So one of the other pieces of the puzzle that we need to take into consideration when we're doing this workup with patients is their physical exam. One of the important things to remember is even though they're in the pulmonary office, their physical exam is not just their lung exam. There are a lot of other findings that can help us figure out the diagnosis of interstitial lung disease. So some of the things that you want to look at are their hands. One of the findings you may find is what we call mechanic's hands. So patients will have these rough, cracked hands, particularly along the edges of their fingers. Just like the name implies, their hands are going to look like they're a mechanic working on cars all day, but they may be somebody that sits at a desk all day and really doesn't have a reason to have these findings on their hands. You may find that they have what we call Grotrin's papules. So those are these red markings on the joints of the hands. You're going to want to look at their face, give a good examination of their skin. You may see what we call a heliotropic rash, so a rash around their eyes. You may find that they have what we call the shawl sign, so a rash across their back and then up onto their shoulders, just like where a shawl would be. These are all findings that can go along with connective tissue diseases. Other things that aren't pictured that you may see are findings like Raynaud's disease. If your clinic's cold, you may actively see it on your patient's fingers. You may find ulcerations on the tips of their fingers. You may find sclerodactyly. All of these physical findings can make us feel like there may be something connective tissue disease like going on with the patient. One of the things that I'll caution you is it's important to recognize that you can look at all these pictures of, okay, this is what a heliotropic rash looks like. This is what mechanic's hands look like. it may not look exactly like the pictures on your patient, particularly if your patient has a different skin tone than the pictures that you're looking at. Our medical reference books are not always good at covering all different skin tones. So I find it's most useful to say to my patients, have you noticed any changes to your skin? Have you noticed anything different on your face? They're usually pretty good at zoning in on, yeah, I've noticed that my fingers have changed, or this is showing up on my face now. Still do the exam in your clinic. Certainly you need to take a close look at their skin, but your patients will probably help you find what you're looking for. So we talked about a couple pieces of the puzzle. The next piece of the puzzle is all of the labs that we send. I'll tell you, my patients, they always get worried when I hand them the stack of lab work that they're going to get. So a lot of it is part of the connective tissue disease workup to say, is any of this related to a connective tissue disease? So we send a whole bunch of labs. We'll send a CK, an aldolase, an ANA, an ANCA, a rheumatoid factor, CCP, SSA, SSB, your SCL of 70. We also send the myositis panel to look for myositis. It includes things like the MDA5, the OJ, the JO1, EJ, the PL7, the PL12. Another lab that we sometimes send is the Hypersensitivity Pneumonitis panel. I will tell you there's a little bit of debate out of how useful this panel is and if it really helps you get the diagnosis. You'll find some interstitial lung disease clinics send it on everybody. Some don't send it on anybody. Sometimes there's a mix. The jury's kind of out on what to do with that. But it is lab work that we sometimes send. And then when we're looking kind of at getting all of this lab work back, the Pulmonary Fibrosis Foundation, again, among many of their references, they've put out a pamphlet for rheumatology and interstitial lung disease, and this is taken from that. So some of the diseases that are related to rheumatology or connective tissue diseases that we see that are associated with interstitial lung disease as well. You can see systemic sclerosis. So about 65% of those patients are going to have some interstitial lung disease. You'll see their SCL 70 come back positive. Rheumatoid arthritis, anywhere from 30% to 76% of patients with rheumatoid arthritis can have lung disease. So you're looking at your rheumatoid factor, your CCP. Your Sjogren's syndrome, about a quarter of them are going to have interstitial lung disease. Myositis, again, looking at the myositis panel. So there's some variation there, about a quarter to 65%. Lupus, we see less ILD, but it does happen. And then mixed connective tissue diseases. We find in our clinic, it's really helpful to work with our rheumatologist when we get back this big panel of blood work that we sent and we have some positive findings. You'll find that sometimes the positive findings mean something, sometimes they don't. Again, like I said in the beginning, sometimes the puzzle pieces fit together nicely and sometimes they don't quite fit together. So we rely a lot on our rheumatology colleagues to help us fit those pieces together. Additional testing that we like to send for patients is pulmonary function testing, 6-minute walk test, sometimes an oxygen qualifying test, sometimes an echocardiogram. So your pulmonary function testing is going to look at spirometry, lung volumes, diffusion. We like to follow the FVC or the forced vital capacity in a lot of these lung diseases. It's good to have pulmonary function testing up front when we're first meeting the patient, but the big thing we like to do is to trend their pulmonary function testing. Gives us a sense of change and also gives us a sense of the trajectory of their lung disease. Sometimes using the speed at which things are changing can help us narrow down our differential as well. 6-minute walk test will give you a sense of your patient's oxygenation, give you a sense of their physical ability, how far they can walk in 6 minutes. This is another test that's good to trend from appointment to appointment. The oxygen qualifying test is a test that we often use, just like it says, to qualify patients for oxygen. So based on kind of CMS guidelines, how to get patients oxygen, this test will support all of the required documentation to get patients oxygen, but we'll also give you a sense of what are their oxygen requirements. Do they have an oxygen requirement? Do they need 2 liters? Did you see them 2 months ago and they needed 2 liters and now they need 6 liters? And then the echocardiogram is another test that we sometimes send on some of our patients. This will give you a sense of, is there another cause of their shortness of breath? Is their heart causing part of this problem? It can look at pulmonary hypertension, although as a reminder, it's just an estimate. but it can be quite helpful as we're working up interstitial lung diseases. And then the other puzzle piece, if we go back to the picture I showed you a while ago that was kind of sitting off to the edge, is the biopsy. And a lot of times this is the big question. Do we biopsy the patient? Do we not biopsy the patient? So again, the Pulmonary Fibrosis Foundation has helped us out here and has put out a position statement, and you can go through all of that. You'll find it on the website. But the big questions to ask are, can you make a confident diagnosis without biopsy? If you can say, okay, I'm fairly confident that this is IPF, or I'm fairly confident that this is hypersensitivity pneumonitis, or I'm fairly confident this is connective tissue disease related ILD, then you probably don't have to biopsy that patient. Why are we going to put them through a procedure that has risks when we can make their diagnosis without a biopsy? Another question to ask when you're considering biopsy is this patient at excessive risk for a post-operative complication? It's great to have an answer as to what their interstitial lung disease is, but if we're going to harm the patient in the process, then we shouldn't move forward with that biopsy. So taking a step back and saying, what risks are involved? And do the benefits of getting this biopsy really outweigh the risks? It's important to have that conversation with clinicians, but also have that conversation with your patients. And then you want to know, will the biopsy results potentially alter the treatment plan? So if I have a plan, how we can treat this patient, and it seems reasonable and seems appropriate, seems like the right plan. If I biopsy them and it's not going to change that plan, do you really need those biopsy results? Or are you sitting between two very different lung diseases and treatments, and you need to know between the two so you know the appropriate way to treat the patient? Then maybe you do need that biopsy. So again, I'm going to refer you back to the Pulmonary Fibrosis Foundation's position statement for more details about how to decide whether to biopsy or not. But those are the big questions you should ask yourself when you're biopsying or not biopsying. So a lot of things to take into consideration when you're going through a diagnostic workup of a patient with interstitial lung disease. And you don't have to do it alone. So it's recommended that these patients be reviewed at a MDD, or a multidisciplinary discussion. So what is an MDD? An MDD is when a whole bunch of people sit in a room, or these days sit at their computers and meet on a Zoom meeting or a Teams meeting or whatever platform you might be using. Usually involves pulmonologists, radiologists, pathologists, sometimes the rheumatologist, to sit and have a discussion and say, okay, here are our puzzle pieces. Here's the history. Here's the blood work. Here's the CAT scan, and the radiologist will go through the CAT scan findings with you. And with each of these pieces, can we make a diagnosis? Do we know what this is? And everybody kind of weighs in. And you also have a discussion about, do we have enough, or do we need that biopsy? And this is a great forum to have a discussion about the risks of biopsy, what you might gain from biopsy. So it's important, if it's possible, to discuss these patients in a multidisciplinary fashion. At the University of Pennsylvania, where I work, we're fortunate to be able to have these meetings once a week to talk about each of our patients. Not every institution has this ability, but if you can participate in an MDD for these patients, it can be really helpful. So that's a crash course, literally a crash course, and what we do to work up ILD diagnosis. And I know we didn't get into all the different diagnoses. That's another talk for another day. But this is kind of our approach as we sit down with a new patient in clinic that comes to us with interstitial lung disease to try to figure out what is their diagnosis. And then thank you so much for attending this talk today. If you have any further questions about this talk, or if I can be of any help to you in the future, or if you just want to learn some more about the Nurse and Allied Health Network, feel free to reach out to me. My email address is on the screen. Happy to communicate with you. All right, take care and have a good day.
Hi, I'm Lanier O'Hare, nurse practitioner with the Interstitial Lung Disease Program at the University of Alabama at Birmingham. I am thrilled to be here with you today to talk about palliative care integration into clinical practice. It almost goes without saying, but given the significant symptomatic and psychosocial burden for patients and their caregivers associated with pulmonary fibrosis, palliative care is certainly a service that's indicated. And what we're going to do today is talk primarily about one specific mechanism of palliative care delivery, and that's primary palliative care. And so what we'll do next is break this up into a discussion about a refresher on palliative care, and then go into different models of palliative care, and then touch on the components that make up primary palliative care and some clinical considerations that you might want to look at as it applies to your practice. And then we'll discuss some of the qualifications and certification opportunities for palliative care. I want to ask you, what does palliative care mean to you? Are there positive connotations such as comfort, support, or are there more negative ones like overwhelming symptoms, hospice, terminal, end of life, loss of hope? So what is palliative care? This is a nice word cloud for palliative care, and it includes many associated terms that people think about, such as life, experience, treatment, illness, quality, hospice. So palliative care can mean many different things to many different people. So what do we know about palliative care? We know it can help manage pain, stress, and sometimes the debilitating symptoms that can be associated with serious illness. It's focused on the whole person and strives to offer support and communication for families. Each member of the healthcare team can participate in ensuring that these 4 areas are considered when managing patient care. For example, the physical aspects of pulmonary fibrosis include disease and symptom management for things like shortness of breath, fatigue, cough, insomnia, and reducing some of the side effects of medications. Palliative care equally supports the emotional aspects of living with pulmonary fibrosis that can include some stress, anxiety, worry, and depression. It can also ensure that spiritual and religious aspects are addressed, and that decisions that are made in patient care are reflective of the patient's values and concerns. And finally, palliative care can really promote socialization and the ability to maintain your patient's physical function so they can do things that are important to them. It can also help them remain active and participate in important functions that can contribute to their quality of life. So, how does palliative care differ from hospice? Sometimes it's fun to look at etymology of a word, and this can help us understand what palliative care is. The Latin for palliative is pallium, and it's actually a term that means a cloak or covering. And that's exactly what palliative care is. It's like an extra layer of support. And both palliative care and hospice can strive to improve quality of life for patients and family members. Quality of life isn't just how good or bad someone's life is. It has to do with symptoms, functioning, psychological and social well-being, and possibly meaning and fulfillment are affected by the disease. And so looking at palliative care versus hospice, we see that there are many similarities, primarily the involvement of patients and families, symptom relief, and varying ways of supporting these patients and their families. The primary difference between the two is that palliative care is indicated for anyone with a serious illness at any time in their illness, at any point in the disease trajectory, whereas hospice is indicated for anyone with a serious illness that is expected to survive less than 6 months. Another primary difference between the two is that palliative care is offered for someone who's still receiving treatment to help cure or manage their disease, whereas hospice is focusing on treatment for symptoms only. You know, when we look at differing models, there are several things that we need to consider. Starting with logistics, you know, what's available to you and what are you available to do? You may have access to a specialty palliative care center. Specialty palliative care is inclusive of a team of specially trained physicians, nurses, APPs, social workers, chaplains, and nutritionists who have received specialized palliative care training and hold certifications. Specialty palliative care can occur in an outpatient setting or an inpatient setting. Consequently, we have primary palliative care, and this can be done outside of a formal specialty palliative care team. And it may involve a pulmonologist, a primary care physician, nurses. Dr. Kathy Lindell's support trial was recently completed. It involved the early introduction of palliative care as a nurse-led intervention at a Pulmonary Fibrosis Foundation center. And the intervention actually demonstrated acceptability and efficacy on knowledge and advanced care plan completion with patients, and also knowledge, disease preparedness, and confidence for caregivers. Additionally, there are hybrid models that may be effective as well. In a study by Muir and colleagues, they found that embedding palliative care into an oncology clinic improved quality of life. So why talk about primary palliative care? Why bother talking about this? Well, as you can see from this Center to Advance Palliative Care report in 2019, there are some significant deficits in the availability of palliative care. The lack of specialty palliative care really does inform the need for us to pursue primary palliative care. So let's look a little bit closer at some of the palliative care components. The Center to Advance Palliative Care tells us that it is specialized medical care for people at any age living with serious illness that focuses on providing relief from symptoms and the stress of serious illness while improving quality of life. And this can occur at any stage in the disease process. Now, primary palliative care serves the same purpose, but how is it accomplished? It's by seeing to the physical and emotional and spiritual needs of patients and often their caregiver. You know, palliative care can address symptoms such as pain, shortness of breath, fatigue, constipation, nausea, loss of appetite, difficulty sleeping. The list goes on and on. It can also help patients gain strength to carry on with their daily life and improve their ability to tolerate some medical treatments. Palliative care can also help patients better understand the choices for their care. And it can benefit both patients and families. Along with symptom management, it can offer some communication and support for families. These are also goals of palliative care. You know, the provider helps the patients and families make medical decisions and can choose what treatments are in line with their goals. I want you to think about what you would be able to provide in your clinical setting with the resources that you have available to you. Now, this slide may look familiar. I asked you earlier to think about some of the terms associated with palliative care. These are actually terms that patients have cited themselves. In a recent study, it was found that individuals with pulmonary fibrosis cited the need for help with comfort, support, overwhelming symptoms, hope, hospice, and end-of-life considerations. These are needs that folks with pulmonary fibrosis have identified themselves. Now let's dig deeper into primary palliative care. We know that it can promote stronger patient-client relationships simply by the nature of the care that's provided. We also know categorically that it can improve quality of life, and it can help facilitate not only informed decision-making, but shared decision-making. Primary palliative care can promote stronger relationships and reduce fragmentation of care. It can alleviate or help alleviate pain and suffering. It can set the stage for empathetic care and help patients to make informed decisions that reflect their values. And it's really an integral part of what it means to be a clinician, to be able to facilitate this. And of course, all of this should occur in the context of shared decision-making. All clinicians who care for seriously ill people should understand the domains of primary palliative care, and if possible, receive basic training in palliative care competencies, and also be encouraged to use these skills to provide disease management and symptom palliation to seriously ill patients. Attention to the psychological, social, and cultural and spiritual needs of patients and families is simply a part of good medical care. Symptoms of depression, anxiety, social stressors, financial stressors can really impact caregiver and patient burden with serious disease. And palliative care serves to help improve this. All clinicians who care for these patients need basic skills in recognizing and treating uncomplicated depression, anxiety, recommending appropriate social supports, and also eliciting and respecting cultural traditions and spiritual preferences. Clinicians should also know when and how to refer to subspecialists when the patient or family needs are not able to be adequately met in a primary care setting. Serious illness communication skills are essential in this setting. Basic serious illness communication skills include communicating bad news, eliciting patient preferences, establishing goals of care, and identifying a surrogate decision maker. It also means deciding about things like CPR, mechanical ventilation, and provide emotional support. These skills are routinely offered in the care of seriously ill patients and should be familiar to all clinicians who provide this type of care. There are several different communication tools that can help facilitate difficult discussions. You may heard of the SPIKES acronym, SPIKES. It's a great communication tool that you can Google if you'd like. And the S stands for setting. Set the stage, make sure you're having this discussion in a private place, and make sure you're involving significant others as the patient would like. The P in SPIKES is for perception. You want to elicit, what does the patient think is going on? What is their perception? The I is for invitation. How much do they want to know about their diagnosis and treatment? And the K is for knowledge. This is when you're going to talk with them about what's happening. And of course, empathy. You want to be able to identify the emotion, acknowledge it, and sometimes silence during this time is necessary. And of course, the S is for strategy and summary. Make sure they heard what you said and set the stage for next steps moving forward. So primary palliative care occurs in several settings. We know that it can work. It's been used for several other diseases besides cancer. In a retrospective analysis, it was found that primary palliative care occurred and was effective for folks with heart failure, dementia, Alzheimer's, and HIV. Primary palliative care can be administered by a nurse practitioner, a doctor, or in the case of the support trial, it can be a nurse-led intervention. And of course, the frequency is really going to be dependent on the patient's needs. I want to touch now on palliative care competencies and take you back for a bit of history. In 2006, palliative care became officially recognized as a medicine subspecialty by the American Board of medical subspecialties, as well as the American Osteopathic Association. Physicians could become board certified in palliative care through a 12-month fellowship at an accredited institution. And during this training, they expose physicians to a variety of patient populations, focusing on symptom management, communication techniques, advanced care planning, hospice, end-of-life care, medical ethics, cultural competence, among others. Currently there exist certificate and graduate programs as training pathways for nurses, for advanced care providers, and social workers to become involved in palliative care practices, such as those offered through the Hospice and Palliative Credentialing Center. Through the certification, expertise is recognized through a validating process. This center offers specialty certifications to hospice and palliative nurses and to other members of the interdisciplinary team. The Credentialing Center offers 6 different certification exams for APPs, RNs, pediatric nurses, LPNs, and nursing assistants, and actually recognize over 14,000 healthcare professionals that hold this credential. And by holding this credential, they're really committing to safe, ethical, evidence-based care. You don't have to go through formal credentialing to offer primary palliative care. There are other options for training. For example, there's a 5-day externship offered through the Hospice and Palliative Nursing Association. And I'm not here to plug a specific program, but this is simply an example of training that you might seek in order to provide primary palliative care in your practice. The palliative care externship is a 5-day immersion course with faculty from leading palliative care programs. And the goal is to provide extensive primary palliative education to advanced practice providers to enrich their competency to care for patients that have serious illness. And this particular course involves didactic work about pain and symptom management, communication, skill building, and program development. It's targeted not only for novice APPs, but also experienced ones hoping to update their skill set. Now, these are just a few of the ways to gain more knowledge about palliative care. Now, guidelines are available from the National Consensus Project for Quality Palliative Care, and they outline some of the key domains and best practices for subspecialty palliative care teams. It's important to see that efforts have also been made to help define primary palliative care skills. Primary palliative care skills are going to fall under the 4 major domains that the specialty palliative care falls under. And curriculum are being developed to help ensure that primary care clinicians and other non-palliative care specialties are trained to provide basic palliative care. Now, this is a really busy table, but it's very, very important, and it helps show more extensive examples of these 4 domains that might be within the skill sets of non-palliative care clinicians as opposed to palliative care subspecialists. Really differentiating the 2 columns between primary palliative care, which is what we're promoting in this particular talk, versus specialty palliative care are that primary palliative care involves the basic management of pain and symptom control, the basic management of depression and anxiety, and basic discussions about prognosis, goals of treatment, suffering, code status. On the other hand, specialty palliative care is going to focus more on the management of refractory pain or symptoms, the management of more complex depression, anxiety, grief, and maybe even some existential distress. Also, the specialty palliative care will focus on assistance with conflict resolution regarding goals or methods of treatment within families, between staff and families, and sometimes among treatment teams. And they can also, as specialty palliative care providers, help in addressing cases of futility. So what will be the future of primary palliative care. Where is it going to take us? Well, the development of primary palliative care curriculum or core curriculum, it needs to happen, and that's being worked on right now by several different entities. Another future direction involves consideration of televisits, palliative care, telehealth consultation, and education for others. This was addressed in a project called Project Echo. It's a model that's been successful in delivering geriatric care and education consultation to rural providers. This particular model has been adapted to provide palliative care education and indirect consultation, thus allowing for some basic palliative care services to be provided to populations that would otherwise have very minimal access. Also, another future direction is the incorporation of several different models. Palliative care for patients with chronic lung diseases such as pulmonary fibrosis should incorporate both primary palliative care and specialty palliative care services. If you have this resource available to you, you might want to consult specialty palliative care for some of the situations that we discussed previously, such as refractory symptom management. A hybrid model or incorporating more than one model might be a future direction that we need to look at. So in summary, we see that pulmonary fibrosis is a condition for which palliative care is certainly warranted, and that palliative care is in fact different from hospice in several important ways, primarily that it can be offered at any point in the disease trajectory. There's also a need for palliative care, but not enough palliative care providers are out there, which makes us look at primary palliative care, which can be provided by multiple disciplines and multiple settings. Now, there are certifications and courses to help with competencies in administering palliative care. Some of those competencies are in the process of being established now. And don't forget, your palliative care practice or offering this service to your patients may be offered in collaboration with specialty palliative care. So with that, I'll take any questions.
So we were looking at this topic and looking at all the commas and the length and the broadness, and we were trying to figure out a logical starting point. We tried to focus on what was important. And what would that be but our patient experience? We can't always control a lot of what happens with them, and we can imagine we know what's going on with them since we know so much about the disease. But any of us who've been on that patient side of the medical world knows how different and how daunting it can be. So our experience still isn't a window into our patient's journey. We have a large support group that Dr. Regu started 25 years ago. Our awesome patient facilitator and Jennifer run it, and the members are well-informed and vocal. So we asked them to give us some feedback about their experiences as patients with ILD so that we could speak from that perspective in all areas of this talk: complexity, coordination, medications, insurance. We posed this question to the group. Briefly, what has been the biggest hurdle in dealing with your disease, process, and care in terms of care teams, workups, insurance, expense, or other? I guess we should have been prepared to take our lumps, specifically about our center and processes. And we got some, which were humbling. Navigating the healthcare system is a challenge. Mostly, we got anecdotes about difficulties in the patient experience, tips on how they overcame them, and hopes for resources and changes needed. So since what they say is the most important and why we are here, this talk will be focused on what we learned from our patients, the experts, about the challenges of care in ILD.
Identifying a diagnosis remains the biggest challenge with interstitial lung disease. It's important for us to understand the process of how it's derived in the potential decision tree, as our patients rely on us to educate and explain the reasoning for testing and the differences in the ILD diagnoses, especially in light of treatments and prognosis. Our patients express frustration in the disease-specific care, as well as diagnosis and timely access to ILD specialists. So interstitial lung disease encompasses nearly 200 different diagnoses, and differentiating has therapy and prognosis implications. For example, IPF, the most common, has the poorest outcome, whereas hypersensitivity pneumonitis, especially if acute HP or non-fibrotic HP, if the causative agent is identified quickly and early, it can often be treated successfully. So identifying which ILD a patient has is often a diagnosis of exclusion and requires many costly tests. There have been several patient surveys in the last few years trying to identify patients' experiences around diagnoses, such as misdiagnosis or delay in diagnosis. One such study is the Intensity study, where 600 patients responded to a survey sent to registered members of the Pulmonary Fibrosis Foundation. 55% reported greater than one misdiagnosis, 38% reported greater than two misdiagnoses, with the most common being asthma, pneumonia, or bronchiectasis. The majority had a delay in diagnosis of approximately 11 months from the time of misdiagnosis to the final diagnosis. And this shows the median time of symptoms to final diagnosis is 7 months, with 43% of respondents reporting a delay of greater or equal than 1 year between the initial onset of symptoms and the final diagnosis. And nearly 1 in 5 reported experiencing a delay of greater or equal to 3 years. The majority of respondents consulted at least 3 physicians prior to receiving their current diagnosis. So the American Thoracic Society Guideline Committees, made up of expert pulmonologists, radiologists, pathologists, and others, have over the years established, based on literature review and clinical trials, practice recommendations on diagnosis and treatments. And these are the big ones from the most recent hypersensitivity pneumonitis guidelines down to the IPF treatment guidelines. So with the delay in receiving specialty care from an ILD center, or with the lack of specialty care in rural settings, it's so important for community providers to use resources such as these to get their patients going down the right path.
Quickly, we also wanted to touch on the assessments needed to work up ILD. This shows a high testing burden. Our patients rely on education from our office RNs, RTs, pharmacists, and medical assistants to understand why we do all these tests and how they affect the diagnostic process. There's a myriad of testing required to tease out a diagnosis and comorbidities, not just one identifying test. The newest test, Invisior Classifier Gene Expression, uses data obtained from bronchoscopy samples to identify UIP patterns to differentiate between IPF and other ILDs. Often the diagnosis requires a multidisciplinary approach to accurately diagnose, with pulmonologist, radiologist, and pathologist collaborating.
So here's a case study of one of our patients that illustrates the complexity of making an ILD diagnosis. In 2006, this 52-year-old male presented to his primary care doctor with a persistent cough. His chest x-ray showed abnormalities consistent with ILD, and he was referred to a local pulmonologist whose workup included a high-resolution CT of the chest that showed diffuse ground glass peripherally in all lobes, although no honeycombing. Pulmonary function testing, his diffusion capacity was mildly reduced. His transbronchial biopsy showed patchy interstitial widening secondary to focal chronic inflammation and variable fibrosis. He was subjected to an open lung biopsy and was consistent with idiopathic pulmonary fibrosis. So he was then referred to an ILD center for a second opinion and potential inclusion into clinical trials. So the ILD center requested the outside slides for the ILD pathologist to review, and his report showed a non-specific pattern in the upper lobe, a UIP pattern in the lower lobe for an overall mixed pattern. So this was before ATS guidelines, before approved antifibrotics, before the NIH IPF net studies. So sort of the unofficial standard of care at the time was to offer prednisone, azathioprine, and N-acetylcysteine. So the patient chose to just receive the N-acetylcysteine and careful follow-up. His comorbidities were also worked up and found to have an abnormal pH, so he was started on a PPI. The next 3 years, he demonstrated a very slow decline. Between 2010 and 2012, he was deemed eligible and participated in IPF clinical trials due to the presence of a UIP pattern on his histology. A CT done in 2013 showed fairly stable with slight decline. And overall, he really had a decline that was much slower than most patients with IPF. So at this time, he was no longer eligible to participate in clinical trials because his diagnosis had been made greater than 5 years prior. Then in 2014, his autoimmune serology was rechecked as he had developed subtle symptoms of Raynaud's phenomena and a esophageal dysmotility. So sure enough, his ANA was quite positive. He was seen in the combined rheumatology ILD clinic where mycophenolate and low-dose prednisone was prescribed. So to this day, 15 years later, he's remained stable, preserved lung function. He still has the dry cough, but he does have some relief with benzonatate. He's dyspnea on hills, but otherwise his activity is quite high. He only uses oxygen for airline flights. So he does have a fibrotic disease, and his case shows how important close follow-up is, and to have a low threshold for subtle symptoms as an autoimmune component may blossom several years after the lung disease was first identified. So our care coordinating tips are take advantage of the Pulmonary Fibrosis Foundation patient education materials. You can either direct patients to their website or download materials or order copies in clinic. You know, we've found that reviewing the information also gave us language to use for when we're speaking to a patient either over the phone or in clinic.
Next, under complexity of care comes identifying and dealing with comorbidities. Almost all patients come with pre-existing conditions like hypertension, diabetes, things like that. But we're speaking of conditions that are more likely to occur because they have interstitial lung disease. These diseases increase the complexity of care exponentially, and we need to be aware of them to correlate changes in symptoms with possible comorbidities. We are the ones who speak to the patients more frequently, so having the tools to clue into these can help alert our physicians to expedite care. When we first started in ILD, there were no FDA-approved treatments, medications for ILD indication. So we tested for and sometimes treated comorbidities, even then as treating such things as pulmonary hypertension at least seemed to help relieve symptoms, like shortness of breath. Of course, we know, however, and educate our patients, that treating these symptoms and comorbidities do not do anything to change the progression of their disease. Also, evaluation for and management of common comorbidities can be beneficial for transplant candidacy. Treating symptoms, especially cough, are difficult. There are no non-narcotic cough medicines that work well. Benzonatate works on the cough neuroreceptors, so it does work for some, but helping our patients with non-medication recommendations is very helpful. These are some cough reduction strategies. Often relieving cough relieves some shortness of breath as people get more breathless when they cough. Gastroesophageal reflux disease, or GERD, is associated with cough, and treating GERD can help reduce cough substantially. There have been many articles written on the correlation and increased prevalence of GERD in ILD. Besides causing or worsening the persistent irritating cough in our patients, microaspiration of gastric fluids is correlated with acute exacerbations, which can make patients more short of breath and hypoxic, and cause acceleration of fibrosis. These are some of the potential causes of reflux. Lifestyle modifications can be very successful in helping decrease GERD. We have a handout for patients of lifestyle modifications like these that we give out in clinic or electronically attached to their after-visit summary. Medications can effectively treat reflux caused by acid, and proton pump inhibitors or PPIs like omeprazole tend to be the most effective if taking a half an hour prior to a meal. Fundiplication surgery is where the fundus of the stomach is wrapped around the esophagus to tighten and reinforce the lower esophageal sphincter to inhibit reflux from the stomach going up and potential aspirating into the lungs. This also blocks alkaline refluxate, which may also impact the lungs when aspirated. In the RAP IPF study, 58 patients with IPF and an FVC of greater than 50% predicted were randomized to laparoscopic fundiplication versus medical management alone. There was no difference in FVC change over 48 weeks, but the surgical cohort had numerically fewer acute exacerbations, respiratory hospitalizations, and deaths without major complications. These tests are done to check for GERD. If the manometry shows no mobility, then the patient's not a candidate for a fundoplication. It will inhibit their ability to swallow. Lack of motility can be exclusion for lung transplantation, though some centers will transplant these patients if they get a J-tube placed to avoid aspiration post-surgery. This is unfortunately most common in those with scleroderma ILD.
Pulmonary hypertension is a recognized complication in patients with ILD and has been shown to be common, especially in advanced disease. So due to overlapping primary symptoms of shortness of breath with progressive dyspnea on exertion or exercise limitation, it may be difficult to detect pulmonary hypertension in patients with pulmonary fibrosis. Subtle clues include exertional dyspnea or fatigue out of proportion to the diffusion capacity, possibly chest pain or syncope with exertion. The World Health Organization has a classification system based on etiologies, with ILD following under WHO Group 3, which is pulmonary hypertension due to lung diseases and/or hypoxia. The patients with connective tissue disease associated PH do fall under WHO Group 1 and are therefore eligible for most PH treatments. If symptoms, ECG or CT show signs of pulmonary hypertension, the initial test of choice is an echocardiogram. The right heart cath is, of course, the most accurate as it shows actual pressures, while the echocardiogram PA pressures are estimated. It's useful to get both, however, as following pressures with echocardiogram are much easier as it's not as invasive and less expensive. So supplemental oxygen is the mainstay of treatment, as oxygen can dilate the pulmonary arterioles and decrease PA pressures in some patients. The 2011 ATS guidelines for treatment of ILD did not recommend treating pulmonary hypertension due to lack of studies showing evidence of efficacy. However, there's now a medication approved for PH-ILD, inhaled treprostinil, so those recommendations may change based on evidence from the INCREASE study. So obstructive sleep apnea is another comorbidity that's more common in ILD patients, and treatment is associated with improved quality of life and decreased mortality. Symptoms include daytime sleepiness, snoring, headaches upon awakening, sometimes dry mouth. The frustration for patients is this diagnosis often requires another doctor, as sleep disorders are their own specialty. So it is possible that the ILD doctor or the general pulmonologist would not treat the sleep apnea as well.
So our care coordination tips are to compile patient education materials on testing and treatment, either from your institution, the Pulmonary Fibrosis Foundation, or the Mayo Clinic and National Jewish have excellent sites. These places have excellent and trusted patient ed materials on their websites that you can print or just give website links. Another factor in ILD complexity of care is the potential for acute exacerbation. One of the issues we see with this is community ERs not being aware of the decision tree when an ILD patient comes in with increased shortness of breath and hypoxia. The unpredictability and severe consequences of ILD exacerbations should be appreciated and have a low threshold to advise urgent evaluation. Most literature on acute ILD exacerbation pertains to IPF. It's defined as acute, typically less than 1 month duration, respiratory deterioration with widespread alveolar abnormality and exclusion of alternative diagnosis, including pulmonary edema. The prognosis of exacerbation in IPF patients is poor. The important thing to rule out: infection and pulmonary embolus, along with assessing the patient for exacerbation. Acute workup should be a high-res CT, CT angio, sputum and labs for infection. Even recently, we had a patient go 6 weeks with being treated for infection without being worked up for anything else. CTA was finally done when he progressed over that time and he had a large pulmonary embolus. Because of delay, he was not able to get back to baseline and now has been referred to lung transplant after years of stability. Clearly, it's important to discern quickly whether the cause of their increased shortness of breath is an acute exacerbation or another etiology, as all have treatment options that help patient outcomes. And the elephant in the room these days is that COVID needs to be ruled out as well. It's important, since most of us evaluate patients on the phone primarily, to know what to ask, to know if they need ER or urgent care or can wait for an appointment. With our assessment, we can educate them on what the problem potentially could be and what could be done to assess. These are the typical questions we ask when evaluating patients who call complaining of increased shortness of breath, with the most important thing to discern is, since they're always short of breath, why did they call today? And again, here are our care coordination tips, and we cannot overstress educating patients and intervention when problems are ascertained from our telephone triage.
We won't belabor the oxygen contribution to care complexity, as we know that there are specific presentations at this summit on just this difficult issue. It takes so much time for those of us caring for the patient, we would be remiss if we didn't mention it. So oxygen regulations cause extra visits, extra time in documenting and paperwork, time with our respiratory therapists, coordinating with DME companies, and so many phone calls from patients and much consternation over service and equipment for both our patients and ourselves. So in order to document and identify the many patient issues around home oxygen, as well as the degradation in service following Medicare's competitive bidding program, the American Thoracic Society convened a working group to develop a comprehensive patient survey. And this group is led by our own nurse colleague, Susan Jacobs. So the over 1,900 patient responses to the survey identified patient education, service, and access to equipment needs that should be used as the basis of initiatives to improve patients' experiences as well as change policy around coverage. The following recommendations were made in the recently published Ats Guidelines. There was a strong recommendation for long-term oxygen use in patients with ILD with severe chronic resting hypoxemia, although there were low quality evidence, and a conditional recommendation for ambulatory oxygen used in patients with ILD with severe exertional hypoxemia. So again, low quality evidence. So indeed, more studies are needed. So insurance provides a basic system of a home concentrator and one form of portability. So anything else most likely will be out of pocket expense for the patient. To avoid any delays in getting oxygen to our patients, we need to make sure the prescription and the documentation is complete. The prescription must be within 30 days of the qualifying testing and a physician visit. There are so many DME inconsistencies with equipment offered or like frequencies of tank deliveries. So really there's been no advancement in equipment over the last decade or so, which has been especially difficult with ILD patients who come to need higher flow options as their disease progresses. Not to mention that liquid oxygen has all but disappeared. So educate. There's actually a lot of information out there. The PF Foundation has a couple of excellent patient education brochures that can be found on their website. We do keep a handful of the Oxygen Basics booklet in clinic. The Thoracic Society Patient Education Oxygen site has oxygen fact sheets regarding oxygen, pulmonary function testing, oximetry, safety, as well as links to various sites with excellent patient information and videos, such as found on the American Lung Association site.
One of our biggest patient concerns that we are inadequately staffed and prepared to address are the psychosocial and family issues that naturally occur when someone is dealing with a severe chronic disease. Also, the end-of-life planning, which is difficult to face. We got the most patient input and comments on these. So many complex needs in this population with a paucity of resources in many areas. End-of-life care, being a burden to family, depression, being questioned on their disability, lack of widely available palliative care. Anytime we mention palliative care and its expansion, we have to mention our friend, colleague, and champion for palliative care, especially in ILD, and activist for the Pulmonary Fibrosis Foundation and patients, Dr. Kathleen Lindell, who's pioneered expanding palliative care for ILD patients. Palliative care is an expanding field that's still not widely available, but the perfect partner for ILD experts and patients as they start to decline to help support quality of life while allowing pursuit of treatments. Pulmonary rehab is highly recommended for its social as well as functional contributions. We also want to give a shout out to the support groups who can be an invaluable resource and support for patients, providing education, conversation with experts, tips to each other, and sharing of health journeys. coordination of care difficulty that is common to all our offices, no matter where we are or how many resources we have, is keeping up with following all the testing and labs our patients have. This slide is intentionally chaotic as that's how our days are. Part of the complexity of care is the challenge of delivering care to those who often are not local. For instance, at the University of Washington, it's a regional care center. So it covers Washington, Alaska, Idaho, Montana, Wyoming, and we get a lot of patients from Oregon and Hawaii. Some of our tips for keeping up: our office has amazing program coordinators who work hard to schedule tests, all associated with appointments because no one lives close. We have an electronic system to enter recalls with what testing should be associated with the return, and we place orders at the appointment for the next appointment, so they're ready to go. To keep up with labs for specialty medications with monthly labs per FDA mandate, we have spreadsheets, lots of spreadsheets. Our doctors also give limited refills, especially on medications like mycophenolate. So we can check to see if they have labs when the medications come for refills. Keeping up with labs is one of the biggest challenges. It takes so much time to remind, get slips to outside facilities, call to get labs faxed that we did not get, talk to doctors about abnormal labs, and answer the other questions that when you call the patient about labs, because, well, I have you, I was going to ask. We ask our patients to share the responsibility by telling us when things they can't schedule are scheduled, especially if they do testing at outside facility, and ask them to call if we do not call them to schedule their next follow-up. Sometimes we get behind. Making patient partners in their care results in better care for them and relieving some stress on those of us trying to care for so many. We added this section as we can't ignore the many issues the COVID-19 pandemic has added to our workload and the stress of our patients. Most prominently for us have been the severely decreased availability of pulmonary function tests and the COVID tests prior to the PFT that needed and prior to other tests. Well, we've seen much delay of care costs as well in disease progression when patients were afraid to come in and with some decrease of appointment availability. Patients are also experiencing more fear and desire for guidance on what is safe to do and not to do. For vaccines, masking, concerns on whether they have immunity, if on immune suppressing medications. Also, there's been a big added psychosocial burden around the embarrassment of coughing and feeling of shunning by others worried they have COVID because of their cough. Here's some tips we've come up with to help streamline the added burden to our already busy offices, and I'm sure you've come up with even more. The most helpful has been coming up with the standard statements from our providers to answer my chart and phone questions more expediently. We've done this with general COVID avoidance tips, vaccines, boosters, etc., and it's saved us a great deal of time. We also have a general threshold rule between ourselves to standardize how much time we find helping people find out outside COVID testing. For instance, we'll recommend they look at the county testing website, but usually won't have time to search for them as we get so many calls on this and it takes so much time that we unfortunately don't have.
So part of our topic includes medications, new medications for interstitial lung disease. So we'll touch on briefly some new meds and old, as this is an important topic that consumes a lot of resources in our office, the quest to obtain prior authorization for medications. So obviously this person ended up with a high copay for their medication, which of course is a huge burden. For most, there are solutions to this problem and we can help guide them to the proper resources. So inhaled treprostinil is the newest of the medications that has come available. New to us usually means more paperwork and procedures, and this is no exception. Treprostinil has been approved for primary pulmonary hypertension since 2009 in an inhaled form, which is what was approved for PH-ILD in April this year. So this is not for treating the ILD, of course, but it's exciting as it's the first PH medication that's been approved for WHO group 3 or PH caused by lung disease. So treating PH in these patients seems to decrease shortness of breath and improve 6-minute walk distance. Treprostinil is not yet on Medicare formulary for PH-ILD, so there has been some delay in obtaining it for those patients, but we found good luck with the approval through the Manufacturer Assistance Program for now. So these are some of the topics that need to be managed, discussed, and followed regarding medications that we typically use. Issues around prior authorization, copays, high copays, patient education, side effect management, and lab surveillance management. We often find that completing prior authorizations or appeals in the most succinct manner and not necessarily add information if not asked. The copays can be wildly varied, so we educate the patient to be sure and request referrals to copay assistance programs or foundations when the specialty pharmacy first contacts them. If the patient does not have insurance or the copay is too high, the manufacturers have assistance programs that are quite generous. Finally, it helps to give the patient as much education as you can at the clinic visit at the time the prescription is submitted around what to expect regarding the medication approval process, the specialty pharmacies and their role, to ask for copay assistance, the lab surveillance requirements, and side effects. It helps to give the patient the material in written form as well. We've developed a one-page succinct outline of the major points patients need to know, as the amount of information can be overwhelming. So that page might include lab draw frequency, the process of the prior authorization, and important phone numbers. Then there's a whole other category of medications that require our attention and authorization. Those that are FDA approved, but not necessarily for the indication that's being prescribed. This is one of the most difficult categories, as they require prior authorization but are often denied. These are medications that we use extensively, like mycophenolate, methotrexate, and sometimes even prednisone. We educate the patients when prescribed that while the FDA has approved the medication, the indications are narrow. It's especially important to tell the patients that they should not accept the medication at the pharmacy if the cash amount is too much, as it cannot be returned. So it saves so much time on hold or in phone trees or phone tag if you can establish one point of contact with the specialty pharmacies. Again, providing the patients with a packet of information at the time of the clinic appointment. We seldom do appeals for mycophenolate, as the denied reason is that it's not FDA approved for this indication. So there really is no point, as no matter your excellent reasoning as to why it's being prescribed, the insurance does not have to pay in that case. And when medications are denied, we again discuss with the patient the options, such as pharmacy shopping, just calling around for the best cash price. In our region, it's usually Costco Pharmacy. Going to goodrx.com for the coupon price and asking the pharmacy to honor that. And with these measures, mycophenolate can be obtained for usually less than $50 a month, which can sometimes be less than the copay is with insurance.
Medications have insurance barriers, but there's also a lot of other insurance barriers. Our ILD centers are considered specialty centers and are often just regionally located. And some insurance does not pay for specialty care out of state. HMOs in state or VA may not pay for specialty referrals or testing out of network. With frequent monitoring needed for ILD patients, the cost of testing and visits may be overwhelming. Oxygen is expensive. There are many regulations for insurance to pay, and the equipment is poor. If test is denied, then peer-to-peer reviewers sometimes do not have an understanding of interstitial lung disease or the monitoring needed, or issues that can arise. Also, telemedicine, which has quickly become a very helpful, important tool, now has out-of-state restrictions, which had been waived during COVID, but now have been reinstated, causing care barriers. So our care coordination tips are that testing should be pre-approved by your financial system unless emergent. However, with most insurances, you can appeal denials of tests even after the fact, and can appeal so the patient can get in-network benefits for your facility if the test needs to be done there. These are some of our tips when writing appeal letters. A couple of years ago, Anne gave a great presentation on this, but just remember to give them transcripts and tests that support your point, and a letter that spells out the reason for denial and why it is not appropriate. We also have journal articles and studies that support the reason for the testing or medication. We'll close with a beautiful statement by one of our patients who, while doing everything possible, has also learned to try to enjoy what he can do, and find new ways to get enjoyment out of a quieter life. The ILDs are a challenging, complex disease process for a myriad of reasons, with difficulties from diagnosis to insurance barriers and all the bumps in between. We do our best to keep up day by day, but remember to take some time and listen to the experts, our patients. We'd just like to acknowledge our other two coordinators, Caitlin and Kelsey, for their assistance with putting together this program. Their input was invaluable in putting together this talk and making it through every day in particular. Kelsey joined us recently from the ICU, and Caitlin has been with us for 2 years per diem and recently received her nurse practitioner degree. Thank you for your attention.
Thank you for joining me today to talk about a topic near and dear to my heart, caregivers. Caregivers bear the heaviest burden, so many things to keep track of. What happens if I forget something? No one told me it would be this hard or take so much time. No one told me I would be so scared. What happens if something happens to me? How do I ask for help? Who do I ask? Who cares about me? This was written by one of our caregivers, and a copy is given in a caregiver goodie bag to every caregiver when their transplant patient is first discharged from the hospital. Caregivers are the backbone of patient care, just as you are a caregiver's backbone, guiding them through this process. Caregivers are keepers of information and family questions to ask. They are the organizers of medical information, blamed when things go wrong, transporters of the patient. Caregivers manage family emotions. Caregivers lack sleep. Caregivers eat too much or too little. Caregivers are underappreciated. Sound familiar? In 2017, about 41 million family caregivers in the United States provided an estimated 34 billion hours of care to an adult with limitations in daily activities. The estimated economic value of their unpaid contributions was approximately $470 billion. Take a minute to write down what your patient caregivers do or should do. Now, write down what you do for your patients. What do you wish you could do for your patients but can't because of time or energy? Who are caregivers? Family members, spouses, relatives, friends, children, the medical team. You are a caregiver. The medical team is the caregiver's backbone. If the patient has complications, the patient's chances of recovery increase exponentially with caregiver involvement. The very presence of this person at the bedside or in the home is significant. Patients hear their voices, feel the touch of loved ones, smell their smells. They know they are not alone. Caregivers are not born, they are nurtured. They need to be encouraged, and mentoring programs can sometimes be very helpful. These are some of the ways you can nurture caregivers. Find ways to encourage them. Often a word, a smile, a pat on the back is all that's needed. Caregivers are influenced by these simple things. You may want to consider a mentoring program or pairing of caregivers to provide more confidence. Don't forget, patients and caregivers now have a legal right to their chart notes. You might want to print out the note and give it to them at the end of the appointment. The more information you can provide in writing, the better. That information shows you are open to questions and want them to understand what's going on. This is a legal obligation under the CARES Act. Almost 60% of caregivers work outside the home. Encourage these caregivers to ask for help from others in the family friend system. They also should check with their employer about FMLA or other leaves of absence, paid or unpaid. They may also be able to work from home or job share. The new paid leave proposals currently in Congress could have a huge impact on caregivers. Once tests are completed, how do you give the patient and family the diagnosis? Is it a conference format? How much time do you allot to this appointment? Think about the setting where the diagnosis is delivered. You may have little control over this, but bear in mind, you are probably giving a terminal diagnosis to the patient and family. Fact-based information is critically important. Be honest as you can. Many patients and families will go to the internet searching. Anticipate that. What do you have to offer to patients and caregivers? Someone who is active in the Pulmonary Fibrosis Foundation or another patient may help. But now, you as members of the medical team are the managers and holders of family stress in ways doctors are not. We will talk about palliative care a little later. This is actually where they shine. Studies show caregivers want accurate, straightforward information about diagnosis and treatment, and they want it early. They want to know what to prepare for. Will my loved one die? What is the life expectancy? How do they die? Will the patient be gasping for breath? Do you provide palliative care referrals in the first appointments? Patients may want to know how you approach symptom relief. What kind of disease-modifying treatments do you offer? Is the patient family interested in clinical trials? What about supplemental oxygen? How bad will my breathing get? What about pulmonary rehab? What about a second opinion? Consider these sites as recommendations for good, solid, unbiased information about pulmonary disease. All of these are peer reviewed and they're written on a middle school level, although some of the terms that they use may require explanation. Palliative care. Palliative care is patient and family and caregiver-centered care. It is provided based on the assessed need of the patient, which can grow over time. Some of you are affiliated with larger medical groups that may include palliative care teams. Get to know them. I find them very, very helpful. Palliative care teams are trained to talk about advanced directives, which every patient should have in their file. Palliative care teams can help patients be more organized, as well as providing a neutral party for conflict resolution with the medical team. Sometimes patients are afraid to change treatment directions because they don't want to disappoint their doctor. The palliative care team can help with this. So remember, palliative care is not hospice. Some people use palliative care for years. Palliative care is not home health care. It does not replace the pulmonary team. It coordinates with the pulmonary team. The need for caregivers can be gradual. Patients may need help with grocery shopping, meal preparation at first, and transportation. Sometimes the need for caregivers is triggered by an event, a sudden dramatic change in health, hospitalization, a fall, mental status change, changes in respiratory needs. Caregivers must share responsibilities. And of course, you as a member of the medical team cannot do this for them. Caregivers should consider with other members of the family and circle of friends how to distribute these responsibilities. No one should carry the full load. Ask who are the caregivers, who is available, who wants to be asked. Spouses, partners, children, extended family, friends, neighbors, church members, and other organizations. Also, think about paid individuals who enter the family system to provide care. They frequently do not have experience with the family. How will they adjust? It's helpful to have a caregiver who acts as the leader. Make sure family and friends understand the diagnosis and the possible or probable outcomes. It's hard to provide an honest explanation. So you might want to provide patient families with written materials and websites for information that they can share with family and friends. Remember, information is power. Someone should always accompany the patient to medical appointments. If it can be the same person, that's best. That way, the caregiver can develop a relationship with the medical team over time. Every patient needs a business plan. Financial issues can be very divisive in a family. Who's the power of attorney for finance? Who will pay the bills if the patient cannot? How will you determine when the patient should give up family control, financial control? What are the details? Is there a prearranged funeral? Does the patient have a healthcare power of attorney? What care do they want to receive as their condition worsens? DNR, DNI? Palliative care teams are very, very skilled at helping patients decide on their wishes, and they may change over time. Also, update family and friends on the patient's condition, as well as their wishes for care. There is a resource list following at the end of this presentation for these kinds of family communications. We could spend hours and hours and hours on insurance. If there is an insurance person in your office, make sure the family has the name and the phone number for explanations of bills. Many times, the most difficult thing to discuss is the patient's living situation. Where does the patient live? Where does the patient want to live? Frequently, this is a contentious issue and can lead to a lot of anger from all involved. Many people see their home as who they are. The patient will, in all likelihood, be resistant to moving. Caregivers should try to see this from the patient's point of view. The significance of the housing conversation cannot be overstated. It can make and break relationships. It can be helpful to get a third party involved, a negotiator, a close friend or relative, church pastor, or someone unrelated from an agency may be of help. These risk factors are sometimes hidden. You may see them in subtle ways. However, they are very significant. Encourage caregivers to advocate for themselves. They often feel awkward about this. If you can see any of these risk factors in play, you should ask them to go for help. These are signs of caregiver stress. And again, encourage caregivers to utilize a counselor or a church pastor or a good friend to help them get through this time. Did you see any of these signs in yourself? As providers, you need to ask caregivers if they need help. Ask yourself if you need help. Caregivers need to acknowledge they cannot be perfect. They need to acknowledge they cannot save the patient. They need to acknowledge they have a right to emotions. The emotional side of caregiving is the most difficult. Depression and anxiety are very common with caregivers. What else should a caregiver do for themselves? Accept help. Focus on what you can do. Have realistic goals. Connect with others. Be part of a support group. Seek social support. Set personal health goals. What should a caregiver do for themselves? They often find an inner strength they didn't know they had. Caregivers are the truth tellers. Medical staff should honor and respect their own needs to sustain your patients and caring. Here are some resources for caregivers and patients. Support groups are sometimes found in disease-specific foundations or organizations. 3 of them available here are the Pulmonary Fibrosis Foundation and the American Lung Association and the American Thoracic Society. The Pulmonary Fibrosis Foundation and the American Lung Association have active support groups which are available on Zoom, and you can locate them by checking their website. These resources are good for keeping in touch with friends and family living out of town or in town. Caring Bridge is one you may have heard of in the past. It is very well known and very popular. Think about these communication tools as a way of giving you a break from answering the phone, keeping up with millions of emails. That can be very draining for caregivers. I suggested earlier that you provide your patients with a packet as they are starting on this journey. I would recommend that this include a pad of paper or a spiral notebook, pencil, pen, a printout from PFF on the diagnosis, pulmonary rehab locations, important phone numbers in the doctor's office. Do you want to share test results? What about any chart notes that you want to release at this time? Direct resources for caregivers are beginning to be available all over the internet. The Family Caregiver Alliance is one of the best known of these at caregiver.com. The Elder Care Locator at eldercare.act.gov is a government-sponsored website as a directory for elder care in your community. The National Alliance for Caregiving is also a wonderful organization and also has support groups. The Well Spouse Association is designed almost completely to take care of the caregivers for someone with chronic illness. Caregiver Action Network is another group that has been around for about 3 or 4 years and is beginning to have quite an impact in caregiver support. Thank you.
Wow, what a great first session for the Nursing and Allied Health Network at the PFF Summit 2021. I'm Jessica Shore, the Vice President of Research and Programs at the PFF. Erin Mahoney, thank you again for all your guidance and support as the planning chair for the non-programming sessions. Also, thank you to the entire planning committee. Your work over the last few, not months, but years has really paid off. And I'm so excited that we have just had such a successful first day. Jamie and Janelle, your leadership of the NON has been so impactful over the last year. Thank you. To our speakers, Lori and Janelle, thank you for explaining the very important ILD coordinator role. A reminder that a doodle request was sent via Mobilize today to schedule our December journal club, so more learning even in December. Jamie, diagnosis is such a critical part of the patient's journey. Thank you for sharing key takeaways. Primary palliative care is such a wonderful resource. Lanier, thank you for sharing your knowledge on this critical topic. The PFF palliative care position statements can be assessed via resources on this current platform and also on the PFF website. Jennifer and Carolyn, your experience really shines through as you address challenges that may arise in caring for your patients living with PF. Your patients really are incredibly lucky to have you and the whole care team be supporting them. Thank you. Including families and loved ones is crucial. Susan, much gratitude for sharing some approaches and ideas today with us. In closing, we look forward to seeing you again tomorrow at noon Central for day 2 of our non-programming. We hope you enjoy the rest of your day.